Hello, my name is Racheal Onah, and I'll be presenting my poster, The Effects of Mindfulness-Based Stress Reduction Programs in Perinatal Depression. So to begin, what is perinatal depression? Perinatal depression is defined as minor to major episodes of depression during pregnancy and up to the first postpartum year. Up to 20% of women in North America have been diagnosed with perinatal depression, showing that this is a public health issue. According to the Canadian Pharmacists Association, the antidepressant SSRIs are first line for moderate to severe episodes of perinatal depression. However, the CPA states that psychotherapy are first line for mild to moderate episodes of perinatal depression. The objective of our study was to assess the effectiveness of mindfulness-based stress reduction programs as a way to treat perinatal depression. The Edinburgh Postnatal Depression Scale was used as our outcome measure as it's the most frequently used self-report measure used in women with perinatal depression in a clinical setting. Studies were limited to randomized control trials, systematic reviews, and meta-analyses. We compared mindfulness-based stress reduction programs to treatment as usual because we wanted to consider the safety of the mother and fetus in women already expressing anxiety and depression during and after pregnancy. Therefore, we looked at how mindfulness-based stress reduction programs can be used adjunctively to pre-existing treatments during and after birth. After applying our inclusion and exclusion criteria and removing duplicate studies, 12 studies were included in this review. If we look at Table 2, here we have summarized different types of mindfulness-based stress reduction programs used in each study, as well as the comparison and the results. Mindfulness-based stress reduction programs included mindfulness-based cognitive therapy, mindful yoga, child education courses, Eastern-based meditative interventions, interpersonal therapy, body scanning, self-compassion and listening, gratitude diary. Online deliveries were also available, such as web-based yoga DVDs, computerized mindfulness-based stress reduction programs, or home-guided sessions. Most studies reported treatment as usual as the controls, without stating the normal treatment. However, 3 studies noted that either interpersonal therapy, waitlist control, or the hospital's routine childbirth education was used as a control. The average program length was 8 weekly sessions that were 2 hours in duration. However, some programs went up to 10 weekly sessions or 2.5 hours in duration. Some programs were as little as 4 weekly sessions or a duration of 30 minutes. 7 of the 12 studies found statistically significant reductions in the EPDS scale in the treatment group. However, all studies stated clinically significant improvements in most participants. The study by Pan stated that 3 points and above in the Edinburgh Postnatal Depression Scale was considered clinically significant. Most studies looked at other questionnaires such as the GAD-7, the Beck Anxiety Depression Scale, the State Trait Anxiety Inventory, and the DAS scale. Overall, the results of these studies found that mindfulness-based stress reduction programs are effective in reducing the severity of perinatal depression. Other findings include an improvement in self-confidence during pregnancy and delivery, as well as MBSRs being an effective way of improving mental and physical health. MBSRs have little safety concerns and may be used in conjunction with standard prenatal care. Our research found that MBSR programs can be delivered online in the comfort of the patient's home. Group sessions also provided beneficial effects in lowering the severity of anxiety and depression in this population. Limitations we found during our research were that there was heterogeneity between MBSR program sessions and lengths within systematic reviews and between studies. This made it difficult to assess which program length and session would be most suitable for perinatal women with depression. Many studies use a very small sample size, which could lead to sampling bias. As the EPDS is a self-report, this can lead to social desirability bias. Some studies had confounding variables, such as women were undergoing psychotherapy or taking medications at the same time as the mindfulness intervention. Future studies should look into whether MBSR programs can be used to prevent depression during pregnancy, as well as future research should investigate MBSR programs in combination with drug therapy. Therefore, I conclude that mindfulness-based stress reduction programs are a viable option for reducing the severity of perinatal depression with minimal adverse effects. MBSR programs may improve the severity of depression in this population. Thank you for watching.